Hello, I'm Andrea Hodapp, a medical student of the class of 2024 at Indiana University School of Medicine. In this video, I will be discussing gastric ultrasound. The objectives of this presentation include a brief review of the literature, indications for gastric ultrasound, general setup and protocol, video demonstrations, and we will walk through how to calculate gastric volumes, including their significance. Pulmonary aspiration of gastric contents occurs nearly once every 2,000 to 3,000 patient cases undergoing elective general anesthesia. Unfortunately, the incidence triples to almost once in every 895 patients if they are having surgery. Complications of pulmonary aspiration are significant, including respiratory failure and multi-organ failure. Providers employ multiple strategies to prevent this from happening, including tracheal intubation, rapid sequence induction of anesthesia, or use of antacids. Notably, patients are instructed to abstain from eating or drinking during various windows of time preceding induction of anesthesia. Despite adherence to these precautions, there is evidence suggesting up to 4.5% of patients may still contain food or high gastric volumes, putting them at risk for aspiration. Gastric emptying times vary significantly between patients for various reasons, including anatomical, physiological causes like diabetes, or specific medication use like opioids or GLP-1 agonists. Gastric ultrasound is an emerging technique with great potential that may be used bedside to visualize and analyze stomach contents. It is a non-invasive, low-cost procedure that is able to reduce the risk of pulmonary aspiration related to anesthesia. Currently, we define a non-fasting state as any solid or thick particulate content or clear fluid greater than baseline gastric secretions at 1.5 milliliters per kilograms in the stomach. Gastric ultrasound is indicated in patients that are unreliable historians with cognitive dysfunction, language barriers, if they're unconscious, or with suspected delayed gastric emptying. This information may be used by anesthesia providers to help determine if an elective surgical procedure should be canceled or postponed, or to select the safest induction and airway management procedure for more urgent cases. Assessment is done by visualizing the antrum in the supine position, followed by the right lateral decubitus position. This is due to gravity shifting gastric contents towards the distal part of the stomach. This might be especially important if trying to visualize gastric contents in a low gastric volume state. It is important to note that quantitative assessment can only be done in the right lateral decubitus position. In patients that are unable to achieve the right lateral decubitus position, the semi-recumbent position is a reasonable alternative, especially for pregnant patients, critically ill, or in traumas. Any ultrasound machine should be sufficient, ideally one with the ability to measure the cross-sectional area of the stomach. Use ultrasound gel as the acoustic medium. If applicable, choose an abdominal setting. A low-frequency curved array probe is most useful, though a higher frequency probe might be useful in small children. Visualize the antrum with the probe in the sagittal position at the level of the aorta, the standardized plane. If not at this level, gastric volumes may be underestimated. First, assess the patient in the supine position, followed by the right lateral decubitus or right semi-recumbent if necessary. This is the general protocol to follow when utilizing gastric ultrasound to determine gastric contents. Attempt to associate the findings via the grading scales shown. As depicted, grade 0 or grade 1, or calculated gastric volumes under 1.5 mils per kg, are considered low risk for pulmonary aspiration. Grade 2, or volumes calculated to be over 1.5 mils per kg, are at high risk. As mentioned, our goal is to visualize the gastric antrum conveniently located in a gravity-dependent position, highlighted in purple. Take a moment to briefly familiarize yourself with the anatomy visualized with the ultrasound. Here, our model is lying in the right lateral decubitus position, and as I scan, the liver is immediately in view, followed by an empty gastric antrum. Assuming the antrum is also empty with the patient in the supine position, the antrum would be a grade 0, suggesting low risk of aspiration. Clear fluids will appear anechoic. If fluid was recently consumed like the model had done, hyperechoic air bubbles will be present, creating the starry night appearance demonstrated here. If clear liquids are found, the cross-sectional area should be obtained and gastric volume should be calculated. In this image, the gastric antrum's cross-sectional area is 27.34 centimeters. Plugging this information into our equation, we now have 27 plus 14.6 times our right lateral decubitus cross-sectional area of 27.34 minus 1.28 times the age of the patient. Assuming this patient is 40 years old, we have a calculated volume of nearly 375 milliliters. Assuming that this patient weighs 80 kilograms, we find the patient's gastric volume is 4.7 milliliters per kilogram. Thus, this patient has a gastric volume greater than 1.5 mils per kg and is considered to have a full stomach, making them above baseline risk for pulmonary aspiration. The model now has both liquid, food, and air in his stomach. As the antrum comes into view, we see the classic frosted glass appearance caused by air preventing visualization. As we look further, we see various echogenicity, and we can even see peristalsis occurring, moving matter within the stomach, consistent with an above baseline risk of pulmonary aspiration. This model is clearly not NPO. Here are my references, and thank you so much for watching this presentation.